and welcome to ST210 Week 10 mini session, Chapter 21, Control of Microbial Growth. As per usual, let's get into our chapter objectives. We got to talk about our key terms. We are going to discuss the three lines of defense of the human body, compare and contrast innate, adaptive, and herd immunity. We're going to talk about active versus passive immunity. We're going to touch on disinfection, decontamination, sterilization of patient care items, and then we're going to finish up thinking of all the material with a good wrap up of what we covered in this mini session. But first, our clinical significant topic. Decontamination, disinfection, and sterilization might not be the most exciting topics, right? But they are so important for preventing surgical site infections, which also known as SSIs, as well as HAIs, healthcare associated infections like MRSA, VRA, CRE, and nasty C. diff. These processes ensure surgical instruments are safe for the patient's use and are shared responsibility in our entire surgical team. Understanding how infections spread is key to avoiding mistakes that could harm patients. We as surgical technologists must stay focused on infection control and consistently follow strict aseptic and sterile techniques, even if the material seems dull. All right, now getting into our chapter. Microbes vastly outnumber humans, and while most are harmless, they can become dangerous if precautions are ignored. Our bodies have natural defenses to coexist with many microbes, but surgical teams must also understand how to use physical, chemical, and thermal methods for disinfection, decontamination, and sterilization to protect patients. So there are three lines of defense. Our skin and mucous membranes is our first line. Intact skin blocks microbes like Staphylococcus aureus from entering the body. Damage from cuts, burns, or abrasions create openings for infection. Skin secretes lactic acid and fatty acids to kill or just stop bacterial growth, while its low pH discourages microbes. Mucous membranes and cilia in the respiratory tract trap and remove pathogens through sneezing, coughing, or swallowing. We also have our circulatory and chemical responses like digestive secretions like stomach acid, intestinal mucus. They kill or trap microbes, aiding in their removal. Actions like peristalsis and defecation help flush out pathogens. The urinary and reproductive tracts are kept clean by frequent urination and vaginal secretions. And then there's immunity, whether innate and adaptive. Now, innate immunity is the natural, non-specific defense that we're born with. Adaptive immunity develops over time as the body learns to fight specific pathogens. Now, when pathogens bypass the body's first line of defense, the second line activates, focusing on internal protection through phagocytes, specialized white blood cells that engulf and destroy bacteria, debris, and dead cells. Blood proteins, complement proteins, and interferons help attack pathogens. Fever increases body temperature to inhibit microbial growth. Iron balance limits available iron to starve the pathogens. We have our inflammatory response that triggers swelling, redness, and heat to isolate and fight infection. And then there's types of white blood cells. Our leukocytes. You have granulocytes. With that, you're looking at neutrophils, eosinophils, and basophils, and granulocytes, which are your monocytes and lymphocytes. Now, these elements work together to detect, isolate, and eliminate foreign invaders, supporting the body's overall immune defense. Now, phagocytes, which is a type of white blood cell, which is a leukocyte, they act as the body's garbage collector. They're clearing out bacteria, clearing out debris, and dead cells. However, not all leukocytes are phagocytes. Your neutrophils, for example, these are the most common and effective at phagocytosis. Your eosinophils, they are active during allergic responses. The chapter talks about macrophages. These are formed when monocytes, which is a type of a granulocyte, they mature in body tissues. These cells are essential for cleaning and defending the body against infection. Now, all phagocytes are leukocytes, but not all leukocytes are phagocytes. Okay, so just keep that in mind. With phagocytosis, this is how phagocyte engulfs and digests bacteria. We start with chemotaxis. Phagocyte is drawn to the bacterium by signals. Okay, then the phagocyte binds to the bacterium. The phagocyte membranes wraps around the bacterium, forming a vessel called a phagosome. A lysosome and the phagocyte, they come together, they merge with the phagosome to create phagolysome. The lysome's enzymes then breaks down and destroys the bacterium. This process is extremely important for eliminating harmful bacteria and debris in the body. With fixed phagocytes, these are cells that stay in specific organs like the liver, the spleen, bone marrow, lymph nodes, and the lining of blood vessels and the GI tract. These organs make up the RES. Now, lymph nodes filter microbes from lymph fluid before it enters the bloodstream. If bacteria gets past the lymph nodes, phagocytes in the spleen, the liver, and bone marrow help remove them from the blood. The process helps keep harmful pathogens from spreading throughout the body, which is extremely important in infection control and surgery. When we look at complement, these are a group of proteins in blood that are activated when needed to fight infection. They help break down bacterial cells in a process called the complement cascade, which enhances phagocytosis by coating pathogens. This system works as part of the innate immune response and does not require antibodies. Now, prostaglandins, these are fatty acids that affect the body in a lot of different ways, including reducing platelet clumping, controlling inflammation, increasing blood vessels, and causing pain. They also help with immune responses and are involved in conditions like asthma and gastric problems. Now, with the inflammatory response, we're talking about the body is injured or it's infected. It releases substance like histamine to increase blood flow to the affected area. This brings immune cells to fight infection and help repair tissue. Classic signs of inflammation include swelling, redness, heat, pain, and sometimes pus. Now, breaking down the inflammatory response. Edema occurs, as you see, the fluid collects in the area, forming inflammatory exudate. If the fluid is greenish yellow, it's called pus. Redness is caused by the buildup of red blood cells in the area. The body's immune cells work to destroy microbes, dead cells, and toxins, producing heat and sometimes fever. Pain is caused by nerve damage from the injury, irritation from the toxins, or pressure from swelling on nerves. If the body successfully controls the infection, the response ends and phagocytes come in and they clean up remaining debris while cells repair the damaged tissue for for healing. Now in figure 21.3, you see lesions of the mouth and lips, okay? They had become very pustular in nature, and I guarantee you it's probably very painful as well. Now, some people are born with genetic conditions where they cannot produce antibodies, meaning their body or their blood lacks gamma globin. Others may have hypoglycemia, which is when they have very low antibody levels. Both conditions make individuals highly vulnerable to infections, which can be life-threatening. A treatment for these conditions is bone marrow transplant, where immature white blood cells are transferred to the patient. These cells develop into lymphocytes, which can then produce antibodies when stimulated by antigens and help protect the body from infection. So we had the first line of defense. We talked about the second line of defense. Now we get into immunity, which is the third line of defense. Now, this protects the body from infection through the production of specific antibodies against pathogens that caused previous infections. The chapter talks about adaptive immunity. This involves lymphocytes producing antibodies to target and destroy specific pathogens. These antibodies are found in body fluids like lymph, plasma, and secretions, and are triggered by the presence of a pathogen. There are two main types of acquired immunity: natural, active, adaptive immunity. Now, after having a specific infection, the body develops resistance to future infections by the same pathogen. This immunity can last temporarily or permanently as the body produces antibodies to fight the infection. Then there's artificial active adaptive immunity. This immunity is gained through vaccination, where a vaccine containing weakened or inactivated pathogens or their components stimulate the immune system to produce antibodies without causing disease. Now, vaccines are often made from weakened pathogens or modified toxins. For example, a smallpox vaccine uses a weakened virus from cowpox, vaccinia, which causes a mild infection but can lead to serious reactions in some cases. Eczema vaccination is a serious eczema vaccinum is a serious skin rash that can occur in individuals with pre-existing eczema or atopic dermatitis after exposure to the vaccinia virus, typically through contact with someone recently vaccinated. Now, vaccines can be made from dead pathogens, like I mentioned earlier, which are quicker and easier to produce, but less effective and provide shorter lasting immunity compared to live vaccines. mRNA vaccines developed for COVID-19 teach cells to make proteins that trigger an immune response, offering protection against future infections without using weakened or inactivated pathogens. Routine vaccines are given to children, adults, and travelers just to prevent diseases, and some vaccines, like those of tetanus, are toxic vaccines. They use inactivated bacterial toxins to help form protective antibodies. With passive immunity, this is when antibodies are transferred from one individual to another, offering, again, temporary protection. This can occur naturally through maternal antibodies passed to a fetus or infant, or artificially via convalescent plasma from a recovered person. Now, antigens are foreign substances that trigger antibody production. Antibodies are produced by B cells, and they bind specifically to antigens just to neutralize them. These antibodies, part of the immunoglobulin class of proteins, are found in various bodily fluids like lymph, saliva, and colostrum. After exposure to an antigen, the body goes through a delayed period called the lag phase. Now, this is where the immune system starts to produce antibodies. This phase involves macrophages, T cells, and B cells. You might want to know which phase does this. Now, some antigens only require B cells to trigger an immune response. These B cells grow into larger plasma cells that produce antibodies to fight the antigen. This is the primary response. As the number of antigens decreases, the plasma cells die off, and the amount of antibodies in the bloodstream also declines. Immune cells begin as stem cells in the bone marrow, which develop into specialized cells to fight infection. The first line responders to infections are cells like neutrophils, eosinophils, mast cells, monocytes, macrophages, and dendritic cells. These cells come from the myeloid progenitor stem cells and are part of the innate immune system. The adaptive, acquired immune system cells, B cells and T cells, develop from lymphoid progenitor stem cells. Now, T cells develop in the thymus and include helper, suppressor, cytotoxic, and delayed hypersensitivity types. T cells do not produce antibodies, but help control antibody production through cell-mediated immune, CMI response. Now, B cells produce antibodies that circulate in the body and lymph node, providing humoral immunity. They live 1 to 2 weeks, but can quickly produce large amounts of antibodies when activated by an antigen. We have natural killer cells. They come from the myeloid progenitor stem cell and act like both innate and adaptive immune cells. Together, B cells, T cells, and NK cells are called lymphocytes. Immunological memory refers to the immune system's ability to remember and respond faster to pathogens it has encountered before. Humoral immunity relies on antibodies produced by B cells, which target and mark pathogens for destruction. These antibodies, made up of 4 protein chains in a Y shape, activate complement to destroy bacterial cells and enhance immune responses. There are 5 types of antibodies: IgA, IgD, IgE, IgG, and IgM that we're going to look at right now. So table 21.2 gives you the functions of these antibodies. For example, IgA plays a key role in protecting mucosal surfaces by preventing pathogens from entering the body. IgD, primarily involved in the activation of B cells. IgE binds to mast cells and basophils, triggering the release of histamine and other chemicals during allergic reactions. IgG helps fight bacterial and viral infections by neutralizing pathogens and activating the complement system. And last but not least is IgM, very effective in activating the complement system and neutralizing pathogens. It is typically produced in response to new infections and helps to control the spread of pathogens. Now, each type of antibody plays a specific role in defending the body against different types of infections and immune challenges. I highly encourage you to make sure you're able to differentiate the antibody class and their functions. With CMI, which are your cell-mediated immunity, this is important for defending the body against intracellular pathogens like viruses that antibodies just cannot reach. So let me break it down how they work. Macrophages and T cells play the important role in CMI. Macrophages identify and consume infected cells. T cells, particularly helper T cells, trigger your immune responses and stimulate other immune cells. CMI and viral infections, for example, in a herpes virus infection, while the virus is outside the cell, antibodies can destroy it. But once inside a cell, the virus is protected from antibodies. Infected cells are targeted by cytotoxic T cells or NK cells, which destroy them. If the virus infected cell escapes destruction, it can become inactive in nerve cells, evading the immune system. The helper T cells activate immune responses by stimulating macrophages to kind of go around and hunt and destroy infected cells. And what they do is release interleukins, which help produce new T cells and B cells. Suppressor T cells regulate the immune response, ensuring that it doesn't overact and harm healthy tissues. Depletion of helper T cells, as seen in HIV and AIDS, weakens the immune system by impairing both antibody-based immunity and CMI, making the body more susceptible to infections. With our myeloid progenitor stem cells, these are stem cells that are actually in the bone marrow and give rise to various immune cells, including macrophages, neutrophils, eosinophils, and basophils. And these are all important for innate immunity. Let's talk about hypersensitivity. Now, these reactions are abnormal immune responses that cause harm to the body instead of providing protection. These reactions can range from mild to actually life-threatening, where the immune system attacks the body's own cell. There's two categories. You have immediate reaction, occurs within a few seconds to 24 hours after exposure, and that's what you're probably looking at on the screen. And then you have delayed reaction. This happens after 24 hours or more, usually involving T cells. There are 4 categories of hypersensitivity reaction that you really want to make sure you understand. Type 1, immediated or IG mediated. This is the most dangerous type and can cause life-threatening reactions such as anaphylaxis. Type 2, which are antibody dependent, it occurs immediately after antigen exposure and often result in cell destruction. Type 3, immune complex. This type of reaction leads to inflammation and tissue damage due to immune complexes that form between antibodies and antigens. And type 4, delayed type or cell mediated. These do not involve antibodies, but instead involve sensitized T cells. Now, these hypersensitivity reactions are important to understand, especially in the operating room, because they can impact patient care, especially during anesthesia or when patients are exposed to certain allergens or medications. Now, let's break them down just a little bit more. Type 1, all right? Again, the most common type of hypersensitivity, immediate allergic reaction. The first exposure to the allergen triggers the production of IgE antibodies that attach to mast cells in connective tissue or basophils in the blood. You have localized reactions. So symptoms are going to vary depending on how the allergen enters the body and where it affects. For inhaled allergens like pollen and hay fever, the allergens enter the respiratory tract. The treatment, antihistamine blocks, histamine receptors, they prevent these allergic symptoms from occurring. We look at anaphylactic reaction. Now, anaphylaxis is the most severe and potentially life-threatening type of hypersensitivity reaction and occurs after exposure to the antigen to which the person has previously been sensitized, most commonly drugs or insect venom. So you have a couple signs. You include itching, skin flushing, headache, ringing in the ears, bronchospasm, laryngospasm, hypertension, tachycardia, and you see the rest up there. Now, anaphylactic shock is where death can occur without immediate administration of IV fluids, steroids, epinephrine, oxygen, or even vasosuppressors. For us, Allergies are marked on the patient's chart and hospital identification bracelet. Okay. When we have hemolytic transfusion reactions, which is a hypersensitive reaction where we have transfused donated blood, maybe it's not properly matched to the patient's body type. A potential fatal, massive, systematic transfusion reaction can occur. In the operating room, the first thing that'll happen is the blood is stopped, like transfusion is stopped. A blood sample from the blood bag is going to be sent to the blood bank to rule out a mismatch. Steroids are given, and then you're monitoring the patient's urine via the Foley, and you're looking for hypovolemia, and the patient may require dialysis to remove the mismatched blood. So just things to think about. There's also an RH incompatibility reaction that the chapter talks about, and that occurs when a pregnant female blood type is Rh negative and the fetus is Rh positive from the father's gene. The red blood cells from the fetus mix with the mother's blood through the placenta, creating a hypersensitivity response and production of antibodies against the foreign or non-self-fatal blood or fetal blood. So if mother's antibodies cross the placenta, they attack the blood cells of the fetus. You have some mild reactions that cause neonatal jaundice that can be treated with phototherapy. After delivery, they put the baby under the light. But there could be serious reactions, fetal demise, brain damage, or even serious developmental delays. Now, type 3 hypersensitivity. This occurs when the immune system mistakenly targets the body's own tissue as foreign and tries to destroy them. This can affect specific organs or the entire body. So here are some of the examples. Rheumatoid arthritis, lupus, multiple sclerosis, sclerodermia, Crohn's disease. There's also single organ autoimmune disorders like type 1 diabetes, where the patient is insulin dependent, Graves' disease, hyperthyroidism, and that bulging eye. And then you have myasthenia gravis, which is muscle weakness. With delayed hypersensitivity, type 4, and this type, T cells, which are not antibodies, again, are involved. When an antigen is phagocytized by a macrophage, T cells become sensitized. Now, upon second exposure, these T cells release substances that destroy the antigen. TB tests, that's why we read them 48 hours. Poison ivy rash, organ tissue rejection. The chapter also talks about immune deficiency disorders. These occur when parts of the immune system, like the T cells or B cells, malfunction, leading to fewer antibodies. So HIV/AIDS, malnutrition, chemotherapy side effects, and the removal of the spleen, also known as a splenectomy. Older adults and individuals with diabetes are also at risk for immune deficiencies. Now let's get into herd immunity or community immunity. Now this is when a large group of people is protected from a disease because most individuals in the community are vaccinated. This reduces the spread of the disease, protecting those who cannot be vaccinated due to reasons like allergies, weakened immune systems, or just personal belief. For a herd immunity to actually work, a high percentage of the population does need to be vaccinated. So, for example, around 95% vaccination is needed for measles to effectively prevent its spread. Before widespread vaccination, one person with measles could infect 11 to 18 others. Diving in deeper with measles. Now, the measles virus can survive on surfaces for hours, making it highly contagious and able to spread quickly in groups. Objections to vaccination, especially in children, stemmed from discredited study by a British researcher who falsely claimed that vaccines were linked to autism. This researcher's data was later proven to be fraudulent, and he had financial ties to attorneys suing the makers of the MMR vaccine. This misinformation has since been debunked, but unfortunately, it still influences some people's refusal to vaccinate. So, for us, it's really important that we understand vaccines and how it protects patients and the broader community, especially in the hospital setting. We also have these things called human behavior. Human behavior plays a major role in the spread of diseases, often unintentionally. Behavioral factors that can help control or prevent disease transmission includes STIs. These can be reduced by or prevented really through safe sex practices, regular screening, abstinence, and avoiding risky behavior. Following vaccination recommendation helps eliminate preventable diseases and protects vulnerable groups such as children and older adults, contributing to herd immunity. And proper maintenance of local government systems like clean water is also important to help prevent contamination and protect public health. Proper food preparation and storage is also important for foodborne infections. So you want to avoid cross-contamination where you have raw meats or eggs contaminating kitchen surfaces. You want to cook food to the correct internal temperature. Avoid unpasteurized dairy products. Keeping your food prepared cold. Washing raw fruits and vegetables. Preventing fecal oral contamination by ensuring food preparers are washing their hands. Anyone who owns a pet, I love my pet. But as pet owners, we still have to make sure that our pets are routinely vaccinating, especially when they are children or pregnant women in the household, because pet urine and feces may contain harmful bacteria. Us in the healthcare industry also follow infection control protocols. Hand washing, right? Wearing our PPE, administering antibiotics carefully to avoid contributing to antibiotic resistance, and then regularly cleaning and decontamination of the surfaces just to prevent the spread of pathogens and reduce healthcare associated infections. Now, in surgical technology, y'all are extensively educated on protocols for decontaminating, disinfecting, sterilizing areas, surfaces, and equipment in the operating room. It all comes in ST300. But here's a quick breakdown or preview of what's to come next module. In environmental controls, so the operating room suite room is designed to reduce the risk of cross-contamination. How? Well, we create clear traffic patterns and zoning to control the movement of personnel, patients, and supplies. Airflow systems with 15 to 20 air exchange per hour. We have positive pressure airflow top to bottom and HEPA filters to remove airborne contaminations and reduce risks from electrosurgical smoke plume and anesthesia gases. Non-porous, non-grouted, waterproof floors, walls, and ceilings so that we can clean a little bit easier. We keep it cold in the operating room, and we control the humidity to again limit microbial growth. And of course, we dress a certain way. We have our personal protective equipment, our PPE from hats, shoe covers, mask, eye protection, and if you're going to be exposed to x-ray, you're going to have a lead apron. We have cover jackets or isolation gowns for contact precautions, and we do not wear a lot of jewelry or any jewelry or artificial nails because, again, we're trying to prevent contamination. Hospitals also establish traffic patterns within the surgical department to control the movement of people and supplies. We separate our clean and sterile items, and there is different attire required in restricted, semi-restricted, and unrestricted areas of the OR suite. With skin preparation, the surgical scrub or preoperative skin prep reduces the microbial load on the patient's skin, creating a surgically clean area, though it cannot achieve sterility due to the presence of resident microflora. Now, after prepping, the sterile team members, we don sterile gowns, we don our gloves, and the patient is draped with sterile coverings to create barriers between sterile and non-sterile areas. Now, don't worry, we're going to break all of this down, but it's really important for you to pay quick attention or close attention to non-critical items, semi-critical items, critical items, and be able to differentiate things like disinfection, low level, intermediate level, and high level. Common disinfectants include isopropyl alcohol and sodium hypochlorite, which is bleach. Again, we're going to be breaking this down next module, but decontamination refers to the process of reducing the microbial population on both human tissues and surgical instruments. We have our initial cleaning. The decontamination process begins immediately after a procedure in the operating room. After the procedure, instruments are transported to a decontamination area where they undergo thorough cleaning, either manually or with mechanical equipment. After cleaning, instruments are inspected for cleanliness and packaged properly to ensure they remain sterile during the sterilization process. Now, sterilization is the process of destroying all living microorganisms, including spore-forming bacteria. Critical items, surgical instruments, and other critical care items must be sterile to prevent surgical site infections. Central Sterile Processing Departments, or CSPD, and hospitals use various sterilization methods based on the properties of the instruments being processed. We have common methods. We have steam sterilization, which is autoclaving, the most common and effective method for most instruments. We have ethylene oxide, used for heat-sensitive instruments, and hydrogen peroxide gas plasma, which is a low-temperature method for sensitive instruments. Steam under pressure, most widely used method. Now, steam sterilization is, again, the most common and effective method for sterilizing surgical instruments. It is inexpensive, reliable, and safe, making it appropriate for most surgical items. The principle of direct contact is the key, okay? Every surface of every item needs to be sterilized. If any part of the surface or lumen is not fully contacted by steam, the item is considered unsterile due to a failure in the sterilization process. With ethylene oxide, it's used to sterilize heat-sensitive or moisture-sensitive materials that cannot be processed by steam. It is effective against all types of microbes, including spores. Non-corrosive, meaning it does not corrode metals, but it has several hazards that they are flammable, carcinogenic, and toxic, and they do require longer aeration after sterilization to remove harmful residues. Your hydrogen peroxide gas plasma can be used instead of ethylene oxide for sterilizing heat-sensitive items. It is a low-temperature process. It is ideal for items that cannot tolerate a lot of heat. And then you have glutaraldehyde. It can disinfect or sterilize depending on the concentration and exposure time. We cannot forget peracetic acid. It is generally safe for most materials, but can be corrosive to some metals. Each chemical sterilization method is designed to address specific challenges related to heat-sensitive, moisture, sensitivity, and the material properties of the instrument being sterilized. Now, the sterilization process assurance monitors are essential tools to verify the effectiveness of sterilization methods. They help ensure that all items are properly sterilized and safe to use in patient care. Now, figure 2115, you see the indicator shaped tape showing the color change, okay? Letting us know that the appropriate amount of exposure for the steam sterilization process has taken place. All right. We put in mechanical indicators. They're produced by the sterilizer unit during the sterilization process. These printouts provide a record of critical parameters such as cycle time and temperature. They serve as a record to confirm that the sterilizer reached the required conditions for sterilization. We have chemical indicators and integrators. Now, while they confirm that the sterilant was present and the process occurred, they do not guarantee the sterility of the contents within the pack. Your external indicator applied to the outside of the package or tray, such as the tape that you kind of see here, some of them have dots. They show exposure to sterilizing conditions. Your indicator that is internal is placed inside instrument trays or packs to indicate that the contents were exposed to the sterilization conditions. Biological indicators contain bacterial spores that are highly resistant to the sterilizing process. These spores serve as a challenge to the sterilization method, testing its efficacy in killing the microorganisms. The biological indicator is the only test that proves the sterilization process was successful in eliminating microorganisms that might otherwise survive the sterilizing condition. So how does it work? Now, after sterilization, the biological indicator is cultured. If the bacteria failed to grow, it indicates the sterilization method was effective. Woo woo. Now, there's type of spores that are used, okay? We have steam sterilization, which is highly resistant to steam but harmless to humans. We have ethylene oxide. The biological indicator contains Bacillus arthropoeus spores, which are resistant to ethylene oxide but not harmful to humans. Now, the combination of mechanical, chemical, biological indicators, along with administrative record keeping, ensures the reliability of sterilization processes, providing confidence that surgical instruments and other items are safe and sterile for use in patient care. Now, on August 8th of 2009, we have a clip from Envision, Infection Control in the Operating Room. Now, this is a healthcare training video for hospitals and ambulatory surgery staff. Let's take a look on infection prevention in the operating room.
The whole means of achieving a decreased rate of surgical site infection goes to that of the surgical team. And we all have to be on a constant state of high alert in order to do everything we can as individuals to prevent what might become a complex and even in some instances life-threatening post-operative infection.
The fundamental goal of the surgical team is to prevent surgical site infections and the transmission of infectious organisms. For this reason, it is critical that all staff who work in this area become aware of how pathogens are transmitted, the general principles of asepsis and infection prevention to combat transmission, and how to incorporate these behaviors into everyday practice.
We have to be the patient's advocate, and we have to think about infection control on a daily basis, even minute to minute.
Everything adds up. You have to make sure that you're doing everything the right way all the time to prevent any incidents of infection that might occur.
Because even one break in technique can lead to an infection, it's important that all members of the OR team practice with a surgical conscience, dutifully performing the practices of aseptic technique so that harmful microorganisms are not transmitted to the patient. There are three main sources of infectious pathogens: the patient, the healthcare professional, and the environment. In order to prevent transmission of pathogens, we must apply aseptic practices to all three sources. Asepsis, by definition, is a condition free from germs, infection, and any form of life. Aseptic practices performed by OR personnel include proper surgical attire and personal protective equipment, surgical hand antisepsis, patient skin antisepsis, maintaining a sterile field, and traffic patterns. It is important to wear the proper surgical attire and personal protective equipment in the OR as required by OSHA. This includes fluid-resistant attire to protect skin and clothing during activities that generate splashes, sprays, splatters, aerosols of blood, or other potentially infectious material. Scrubs are not PPE because they're not impervious to strike through. Surgical attire includes a mask to cover mouth and nose, a hood to fully cover hair, eye cover, clean, closed-toed shoes, shoe covers if exposure to blood or body fluids is anticipated, and especially over cloth shoes. If part of the sterile surgical team, don a gown and then sterile gloves. And non-scrub team members may wear a jacket with cuffs closed in the front and tight against the body. Items that should not be worn in the OR include personal hats without coverage of a surgical bouffant cap, turtlenecks, dangly jewelry, long-sleeve shirts under scrubs, untucked shirts, and uncovered cloth shoes. Surgical attire for scrubbed personnel should be changed when contaminated or penetrated, after a case ends, and upon leaving or re-entering the OR environment according to policy. Hand antisepsis is the single most important way to prevent the transmission of disease in any healthcare setting. Every member of the OR team should begin the day by washing their hands with soap and water per facility policy. Personnel working in the sterile field will follow with surgical hand antisepsis according to CDC and AORN guidelines.
All right, which brings us to the end of our mini session, Chapter 21, Control of Microbial Growth. Now, what did we do? We explored key aspects of infection control and sterilization in healthcare settings, particularly in surgical environments. We covered the importance of decontamination, including cleaning instruments and surfaces after use, ensuring proper storage and transport. Sterilization methods like steam under pressure, ethylene oxide, and hydrogen peroxide gas plasma were discussed, highlighting their roles in eliminating harmful microbes. The significance of sterilization process assurance monitors, such as biological indicators, chemical indicators, and mechanical monitors, ensure that every step of the process is reliable and effective. We also explored how human behavior impacts disease transmission and the importance of practices like vaccination, proper food handling, and hygiene to prevent infections. The concept of herd immunity was highlighted, especially in the context of measles and the impact of misinformation on vaccination efforts. Understanding these protocols and practices, we can minimize risk and maintain a safe, sterile environment for patients. If you have any questions or concerns on any of this, please do not hesitate to reach out. Looking forward to seeing everyone in the live session.